Welcome again. In this short video about 6 minutes, we will talk about cystogastrostomy of a pancreatic pseudocyst using plastic stents. We all know that pancreatic pseudocysts are localized pancreatic collections occurring after 4 weeks of the acute pancreatitis, and it usually contains turbid fluid with no or minimal amount of necrotic material. This is in contrast to walled-off pancreatic necrosis, which is localized pancreatic collections occurring also after 4 weeks of acute pancreatitis, but contains large amounts of necrotic material. This video will show the drainage of pancreatic pseudocyst, which is better achieved by plastic stents. No need for metal stents, although it may be drained by metal stents effectively, but it is also effectively drained by the cheaper plastic stents. First, we introduce the echondoscope in the stomach, and here we can see obviously the bulge in the posterior gastric wall. This is the posterior wall and this is the lesser curvature. This is the posterior wall bulge, which is a classic anatomical location of the pancreatic pseudocyst, which is a retrogastric in location. Even if there is no bulge, we can visualize the bulge by the endoscopic ultrasound, and this is an advantage of endoscopic ultrasound. It can perform cystogastrostomy even without obvious bulge, but the usual upper endoscopy can do it except with the presence of a bulge, but EUS can do cystogastrostomy without the presence of gastric bulge. But here in this case, the gastric bulge is very clear in the posterior wall of the stomach. Yes, this is a very obvious bulging in the posterior wall of the stomach. Now we will shift to the echondoscopic picture. This is the echondoscope inside the stomach, and this is the gastric wall, and this is the stomach cavity, the gastric cavity with fluid inside, and this is a very large pancreatic pseudocyst. This is the wall, echondoscope inside the stomach, intragastric fluid, and this is a large pancreatic pseudocyst. Here, before any maneuver, we should do two important things. One is measuring the wall here, the wall of the stomach and the cyst. Here, this distance. We should choose a distance better to be less than 1 centimeter. Better to be less than 1 centimeter. We need close contact between the cyst and the stomach to minimize leakage as much as we can. So this distance, I think, is less than 1 centimeter. The second is to apply Doppler study, and this is the second main advantage of EUS guided cystogastrostomy, to avoid intervening significant vessels to avoid bleeding. Yes, here, this is a large cyst, and it is a symptomatic cyst. It produces symptoms of the patient because it is compressing the stomach. It is compressing the stomach with repeated vomiting, so it should be drained. And here we apply Doppler, color flow map, or color flow Doppler, and here this is a vessel, but fortunately enough, it is away from the needle path. The needle arises from this side, at this mark. So the needle will go like that, and here the vessel is away from the pathway of the needle. Here we will start to puncture the cyst by 19G needle. By 19G needle, usual needle. The needle of fine needle aspiration, not fine needle biopsy, fine needle aspiration, and should be 19G because it will adapt or will allow the passage of our wire, which will be 0.035 wire is the best. Yes, here this is the needle, 19G needle, and we punctured the cyst. Okay, this is the needle, and then we will withdraw the stylet of the needle and introduce our wire 0.035 wire. Yes, I'd like you to observe the passage of the wire. We can observe the passage of the wire through the sonographic view, the endosonographic view, as well as the screen. Here I can see through the endosonographic view. I can observe the wire going like that and doing one coil or one circle or one loop. Better to do two loops. So we'll observe the wire will go in here and doing coil. Yes, observe with me. I am now introducing the wire inside. Yes, it is wire introduced, and will, yes, here's the wire. It's coming here and we'll do a loop or a coil. Yes, goes like that here, and we can observe it again. We can see it again. Now, here this is the wire. And the wire, yes, here this is the wire, and going like that. So we have 1.5 coil or 2 coils of the wire. So it is a suitable place, and then the wire inside. And here I can see also the wire by the under the screen, and this is the wire here, and this is 1.5 loop of the wire. Okay, and here the needle and the wire is going perpendicular to the wall of the cyst. Here the wall of the cyst, and here the wire is not kinked at this area. Very important that the wire is straight at this area, not kinked. Because if it is kinked, when I introduce the cystotome or the balloon, it can push the wire in this direction and may dissect inside the wall, and this will lead to complication, especially if the stent is positioned in this false track of the wire. So the wire will, it is better to be, or should be straight in this area. Okay. Now the wire is well placed, and now we'll introduce the cautery and pierce the wall of the stomach and the cyst by a cystotome. We should use cautery. Some may introduce the balloon without cautery by cystotome, but it will be very difficult. To make things easy, you should puncture first with cystotome, and I prefer 6 French cystotome. So the 6 French cystotome, I will introduce now the 6 French cystotome. Yes, it will be introduced now. Yes. Puncture with a cystotome. Yes, here's the cystotome, and now the cystotome is inside. The cystotome is inside. Yes, this is the cystotome. Is inside the cyst. So I punctured the wall by 6 French cystotome with cautery, and here the cautery is endocut mode or cut mode or endocut mode. And I should apply cautery before pushing. I apply cautery here, and then for a few seconds, and then pushing the cystotome, it will pass rather easy to the cyst. And I will withdraw the cystotome, and we will withdraw the cystotome, yes, and we now introduce the balloon. Yes, this is a CRE balloon, the usual CRE balloon. Most of the endosonographer introduce 2 stents, 2 double pigtail plastic stents, but some prefer to introduce only 1 double pigtail plastic stent, 10 French, to shorten the maneuver. 1 wire and 1 stent. But if you introduce 1 stent, it is better to dilate more for a more diameter. We use the CRE balloon at least 12 millimeter, 10 to 12 or even 15 millimeter. We dilate more if we intend to introduce only one double pigtail stent. Here we will dilate up to 12 millimeter. This is the CRE balloon, and I can do it all these maneuvers, I can do it under endosonographic guidance. No screen till now. Yes, this is the balloon. Here part of the balloon, half of the balloon, and this is other half of the balloon inside the lumen of the stomach, and here this is the wall. So I expecting to see a waist in this area, but not in endosonography, but it is better to be seen under the screen. So I will now inflate the balloon. Yes, this is the puncture site and this is the balloon. This is the part of the balloon, the distal part of the balloon inside the cyst, and this is the proximal part of the balloon inside the stomach, and here this is fluid inside the stomach. Yes, this is the balloon, very well seen, and this is the diameter of the balloon from here to there. It is about 12 millimeter, and here very nicely seen on the screen. Yes, this is the proximal part, distal part, and this is the waist. This is the area at the gastric and cyst wall. And I will keep inflating the balloon till the target, which is 12 millimeter. And here there is loss of the waist. This is very nice dilatation. And then the last step is to introduce and here this is the balloon appearing in the gastric in the endoscopic view of the of the echo endoscope. Yes, this is the balloon, and here this is the inflated balloon. And when I deflate the balloon, I expect there will be gush of fluid from the cyst inside, from the tense cyst, large cyst inside the stomach. The patient is much better to be intubated to prevent aspiration when there is gush of fluid from the cyst to the gastric wall. And now the last step is to introduce the double pigtail plastic stent over the wire. Yes. We are now preparing the double pigtail stent. And I prefer to introduce the distal half of the plastic stent under sonographic guidance to keep the position of the echo endoscope very adjacent to the gastric wall or opposed to the gastric wall, in order not to lose my position. If I tried to look at the gastric view, then I should do some downward deflection by the big wheel. The big wheel is away to push the big wheel away, to do downward deflection of the echo endoscope to see the stent, and this may make you lose your best position. So I introduce the distal half of the stent under endosonographic view, and then when I reach about its half as seen at sonography, then I shift, then a large part was introduced, so I get very nice distance of the stent inside the cyst, so I can complete the maneuver under endoscopic view. And this is the endoscopic view, and you notice here that after balloon dilatation there is a large amount of fluid. Yes, large amount of fluid coming from the cyst to the stomach, from the tense cyst with high pressure to the stomach. And here I am introducing the proximal half of the double pigtail stent. I am pushing till the black mark come, and here I expel the rest of the double pigtail stent outside. So EUS guided cystogastrostomy can be done by plastic, 1 double pigtail 10 French plastic stents, or 2 double pigtail plastic stents, 7 French and 10 French. can be done in cystogastrostomy. Gives very nice results in contrast to whole of pancreatic necrosis, which is better to use self-expandable metal stents, especially the LAMS, the lumen opposing metal stents. But here in pseudocyst we can use plastic stents. Most of the experts prefers 2 double pigtail stents. Some produce only one double pigtail stents, and there are many articles saying that both as effective, the single stent and 2 stents, single stents or 2 stents, and others are saying that the 2 stents is better than 1 stent because if there are 2 stents, there is a thin film, the space in between the 2 stents can drain fluid. But if you decided to use single double pigtail plastic stent, then it is better to dilate to a wider distance, to use a CRE balloon at least 12 millimeter, not 8 or something like that. And lastly, I should say that drainage of pseudocysts in the first instance should be done in symptomatic patients. In the past, they are saying that asymptomatic pseudocysts without symptoms, but more than 6 centimeters should be drained. But most of the experts now, or most of the recommendations are saying that don't drain pseudocysts except if they are symptomatizing. For example, secondary infected, or for example, compressing the stomach, so producing repeated vomiting. Because more than 50 to 60% of pseudocysts can resolve spontaneously. So if the cyst is asymptomatic, no symptoms, leave it for more and more time, because they are not producing any harm to the patients, no symptoms, and there is a chance of more than 50% to resolve spontaneously. And thanks for your attention.